All right. Well, why don't we get going? So we got several pretty good cases this morning. Pretty um, mixture of some inflammatory and some neoplastic things here. So somebody want to take us through this one?
I can start here. Yeah, it looks like we have potentially either a punch or maybe like a shave of something that kind of shelled out on the right side.
Good. Yeah, I think that's probably what they did. They probably thought it was maybe some kind of dermal nodule, and maybe they took
Uh-huh.
a punch, and then they said, "Oops, there's something deeper here." So yeah, good.
Um, and it looks like, the epidermis looks overall pretty normal, and then kind of in the dermis, you start to see what looks like, kind of like duct-like structures or like a cystic-like structure with this kind of like myxoid blue stroma.
Good. Look at this piece over here also. Okay, so obviously you're thinking it's an epithelial neoplasm. It's like ducts. So
Yes.
obviously then it's not squamous epithelium like the top of the epidermis and whatnot. So you're thinking about adnexal, right? So what's your approach when you think of an adnexal neoplasm?
I guess well, I'm not an expert, but I started thinking, trying to differentiate between like if you're seeing it look more like follicular or sweat gland. So if you're seeing like ducts and things like that, lean more towards like sweat gland, and then like what kind of stroma you're seeing.
Yeah, that's
Um,
good. That's what we want you to be able to do is sort of say, okay, so it's epithelial, and then say, well, it looks like it's adnexal. Then you've got think of the different, 4 or 5 different subtypes of adnexal neoplasm. It's sebaceous, follicular, eccrine, apocrine, neural. Some people kind of throw vascular in there, maybe, but there's really not a lot, luckily. And I agree with you. You don't really need. I wouldn't lose a lot of sleep over whether it's eccrine or apocrine, but if you kind of get it into the quote sweat gland category, that's good. And then when you see ducts, that's exactly what you should think about. So that's good. And we're going to higher magnification. Can you tell anything about these little glandular structures here?
um, yeah, and so it looks like, some of the spaces are a little bit more dilated, and then but then some of them are smaller, like uh there was almost like small little like tubule looking things elsewhere, but these ones look just kind of like dilated ducts there.
Yeah, and if you look carefully at this, notice, and this is a helpful clue when you're trying to distinguish between eccrine and apocrine. And I don't, again, I'm not going to, you don't really need to do that a lot, but just so the board might expect you to be able to at least recognize pretty classic eccrine differentiation. But you see these small, round, basophilic cells, cuboidal cells like this, admixed with cells that have a little bit more clear staining cytoplasm. That's classic for eccrine. If you see that, now, you may see just a solid aggregation like a pleomorphic or something like that. And, people kind of argue whether that's really eccrine or apocrine. We don't really care that much. But if you see this kind of morphology, that favors eccrine. Okay, so that would just help you there. So think of, small cuboidal round cells and clear cells, eccrine. And that makes sense because if you're dealing with the eccrine sweat gland, those cells need glycogen to have their ATP dependent secretory mechanism to pull out the ions and whatever. So you need that. So that's why those cells have a clear morphology to them. So it's a ductal neoplasm. It's most likely eccrine. And then what you said something about the stroma that was helpful.
Yeah, okay, and that's helpful with the eccrine. But yeah, the stroma looks very like basophilic, and it's kind of like getting denser in some areas. And I almost was like wondering right here if it's starting to look sort of like cartilaginous.
Yeah, that's exactly right. So what do you call that when it sort of becomes looking like cartilaginous? What's the term for that?
Is it like chondroid, or is there a different
It is
word?
chondroid, you're right. And we refer to that as chondroid metaplasia. So in other
Oh,
words, plasia kind of means, forming it, if you will. So it means that it's basically becoming something that's meta, not exactly like what it should be. It's forming something that's sort of adjacent near what it normally would be. And basically, normally what you have is just a lot of mucin. So anytime you get tons of this hyaluronic acid, which is what you're seeing over here, even if it's in a, like a cutaneous myxoma, sometimes those can develop some cartilaginous metaplasia in them. So this entity very commonly gives you that. So you know the answer already, right? So what is this diagnosis?
Yeah, so the cartilage is making me think of a mixed tumor.
Yeah, that's exactly what this is, a mixed tumor. And what's the other name for mixed tumor?
Is that like chondroid syringoma?
Yeah, and it's a pretty good name because it's got chondroid in here, and then it's got the little areas that look a lot like a syringoma. And so, we think of a syringoma being an ecrine entity. We're talking about ecrine syringoma, and you look up here, there's another little larger aggregation there that almost looks like a hydrocystoma right over here. And then if you go back to the other one, that's the other thing about this, by the way, these things, if you read the textbooks, they give you the classic descriptions and you look at it and say, wow, that's great. I've memorized that. And, you'll live happily ever after. But if you start actually looking at some of these lesions under the microscope, occasionally you'll find that they don't read the textbook all the time. They have some unusual morphologies. Like if you were to just see this lesion alone right here without the other, you'd probably think of that maybe being more like a tubular adenoma of some sort. And maybe some of these cells almost begin looking like they may have some apocrine differentiation. They're larger, they're more epithelioid in a way. They may even have a little bit of snouting on them. So you can see that this doesn't look like a classic field of a chondroid syringoma. This doesn't look like a syringoma at all here. So just, realize that even though we say that and we describe everything that's, in a book chapter, in the real world, things sometimes look a little bit different. So that's good. So this is a nice example of, we call this a mixed tumor. For a bonus point, if you will, what other place in the body can you see an entity that looks almost exactly like this, but it comes from a different origin than ecrine differentiation?
Oh gosh, I didn't, we saw this on my path rotation recently. Is it the salivary glands?
Yeah, good. Salivary gland. And what do you call it when it's in that location?
It's I can't remember, like pleomorphic adenoma.
Yeah, that's exactly right. Pleomorphic adenoma. It's basically analogous to a mixed tumor of the skin occurring in the salivary gland. They look pretty much the same. In those lesions, they actually have myoepithelial cells admixed with the sebaceous or the salivary ducts and some of the glandular elements that are in there. But they can get chondroid differentiation that also. And sometimes the cellular component can really predominate, and you just get very few little ductal structures and maybe very little of the chondroid material. So that's just something to remember. I don't think the board's going to ask you anything about that, but at least you say you've heard about it. If you ever biopsy somebody's lip and it comes back as that, you'll kind of know what it means. Okay, another process here.
I can do this one.
Hey, great.
So I initially thought this was a punch, and now I'm like, maybe it's a shave or like an excisional biopsy.
I think it probably is a punch. Just, sometimes if they squeeze the punch, it looks like it might be an Adson's forceps there. And the other side might look a little bit more, this one's a little bit more like a punch over here, possibly. So, but it's got some artifact in there. So that's one of the things you have to learn in pathology is sort of how to tune things out. A lot of extra noise. So you have to learn how to sort of forget the artifacts and focus on the stuff that you're really interested in.
But sort of on scanning, it looks like there's a little something going on in the epidermis. It's hard for me to see exactly what it is, like maybe some spongiosis or inflammation there. And then
on a scale of 1 to 10, where are you going to put the inflammation here?
Like dermal, maybe.
Or maybe about -1. I mean, it's just hardly inflamed at all, right? I mean, it's just
Yeah.
not much inflammation. And so when you see that, that kind of raises a differential diagnosis. If you look at somebody who says, well, it doesn't look like there's very much inflammation here. It certainly doesn't look like a neoplasm. So you have to think about the 9 inflammatory patterns, and you can kind of wipe out about 8 of them, pretty quickly. If it's inflammatory, it's going to be just a very sparse superficial perivascular dermatitis. And when you get into that category, unfortunately, there's probably about 30 or 40 things that can cause that. And you have to sort of think about it. But there's one other of the 9 patterns that sometimes kind of gets forgotten about a little bit. And you kind of have to think about that also.
Yeah. So what I was trying to determine is is the collagen basically thickened centrally, or is there something going on in that central portion of the punch where it's kind of fibrotic, like a scar, because it seems to be oriented more vertically.
Okay, looks like there's so good. You're in the category of the fibrosing and sclerosing disorders. So that's good. So that's one of the 9 patterns that we sometimes kind of forget about.
Exactly.
And if you look up here, you've got this bluish gray material that's probably ciliary elastosis. But then you look in this area over here, and this is pretty helpful if you look in this zone right over here.
So it looks, I mean, there's epidermal atrophy, and
Yes,
there's
epidermis is totally atrophic, right? What about, and there's some
Um,
dilated blood vessels.
mhm.
And then what about this collagen right in here?
Kind of hyalinized.
Yeah, good. So when you see hyalinized collagen, what does that sort of trigger to you when you see that?
Is it like radiation fibrosis?
Well, it's think about the pattern.
Mhm.
So if it's hyalinized, it basically means there's homogenization of the collagen bundles, and there's usually a decrease in the number of fibroblasts. And so if you look right in this area, there's almost no fibroblasts here. There's very few. So this is a sign of sclerosis, and sclerosis is seen in a relatively few number of conditions. So that's helpful. You mentioned radiation dermatitis. That's one of the diseases that can cause that. And if you see dilated blood vessels, and you see sometimes, this one doesn't have it quite as good, but if you see some kind of irregular, bizarre fibroblasts, sort of like here, that's a good clue that that is very much likely the diagnosis. And notice that it's also relatively superficial. It's not going all the way down to the bottom here. It sort of seems like most of the changes are kind of up in this area right in here. So this is chronic radiation dermatitis. This field right here is really a nice example of that. Now, I don't think the board examination would expect you to distinguish among the sclerotic disorders that you can see here, but name a couple of other things that can give you sclerosis in the dermis, primarily, that you have to be concerned about when you see sclerotic collagen like this.
I mean, so the differential I was thinking was like a burnt out, like morphia, basically.
That's one thing. Yeah, morphia can definitely give you sclerosis. Of course, that you would think would kind of involve, the lower part of the collagen and whatnot. But yeah,
exactly. That's why I was kind of leaning towards the radiation.
Yeah, which you're right. That's the correct answer here. So that is
right. Other things, maybe like GVHD, but I think
that can do it. That can give you, there's just the late stage sclerodermoid sclerotic variant of GVHD could give you something analogous to this, usually more diffuse, dense sclerotic collagen of the reticular dermis as well. And usually, now here, this is a good example of these bizarre fibroblasts. But look at that thing. That's kind of a weird looking cell there. And some of these are sort of bizarre. And that's kind of helpful when you're distinguishing between chronic radiation dermatitis, say, and morphia or something like that. Does morphia usually involve this part of the dermis here?
I think it's typically deeper.
Yeah, it's usually the reticular dermis. And what do we call it when we get reticular? We get the papillary dermis involved and the reticular dermis involved with sclerosis in that situation.
like, I'm not sure what you're getting at on like scleroderma now. Like, I think it's maybe more like lichen sclerosis. If
Yeah, exactly. When you see the sclerotic changes kind of confined to the papillary dermis,
Mhm.
edema, you get thing in the epidermis, and sometimes hemorrhage into the dermis as well. That's lichen sclerosis. When it gets down into the reticular dermis, we just by convention say, well, lichen sclerosis doesn't get that deep. We say it's morphia, and you'd be surprised how many times we see what looks like morphia deep and lichen sclerosis at the top. And clinically, it may look more like LSNA. It may have the ivory white appearance and atrophy, but if you biopsy, it actually goes all the way into the reticular dermis. So we call that morphia with features of lichen sclerosis. So this is chronic radiation dermatitis. You need to think about some of those other entities that you mentioned. Some helpful clues to this versus some of those. Again, the bizarre fibroblast, the relative superficial location of it, and the dilated blood vessels help you. Usually you don't get edema with this. That's seen more commonly with LSNA, but this is chronic radiation dermatitis. And probably, what this patient may have had like maybe a basal cell treated with radiation therapy, and then they thought maybe it recurred and they decided to take another biopsy or something. So I don't know. Usually to get this kind of change, it's not the kind of radiation that's used for like, when you're radiating a deep, say, lung cancer or something like that. Those usually are electron beam and things like this that go deeper and they sort of spare the skin. So you don't get as much radiation damage usually in that situation. They can kind of dial it into the deeper areas. So anyway, this is a good example of that. And just know the differential diagnosis of the other sclerosing disorders, sclerodermoid, graft versus host, some of those kind of sclerodermoid PCT. Those are some things to kind of think about when you're looking at the sclerosing disorders. Lupus sometimes can do it also. Okay, anybody want to give this one a try?
Yes. Okay, this is looks like a shave.
Yeah.
And, I think that the action here is mostly in the epidermis and I think some of the papillary dermis too.
Good. And this is one of the reasons why I really don't like shave biopsies of inflammatory skin diseases, because you can't really tell about the deep part. And I wouldn't be one bit surprised if we had a deeper biopsy that you'd see some inflammation down in some of the mid to lower blood vessels also.
Mm-hmm. I think, going from the top down, there's parakeratosis with, I think there are neutrophils within the corneum there. Or if they're maybe lymphocytes as well. I don't know if I don't think there's newts in the corneum itself, but definitely within the epidermis. And then I think the thing that's striking me most is where your cursor is, like all these thrombotic vessels with perivascular inflammation.
Yeah, there's perivascular inflammation. And then what about is it purely perivascular?
No, I mean,
it's really not. I mean, you can't really draw a nice clear line between the base of the epidermis here and where that inflammation kind of ends. There's some interface dermatitis, if you will.
Yeah, definitely. I still struggle with this, but I think this is almost more, I would lean more towards lichenoid, like it's really obscuring the junction to me in some ways.
Yeah, if it's obviously there's two patterns. There's interface dermatitis and lichenoid. And sometimes you don't get a really dense band-like lichenoid infiltrate, but this would probably, like in this area here, be focally lichenoid. I would agree with you right over here. So I say again, the old saw that the diseases don't read the textbooks. They don't always look like classic lichen planus when they're demonstrating a lichenoid pattern, but you can see there's definitely obscuration of the interface here. You just can't see it all over the place. And what about the epidermis itself? The pattern of the epidermis, is that a normal epidermis? You
mentioned it's irregular.
Yeah,
for sure.
And is it okay? So it's a regular psoriasiform, right?
Right, it's acanthotic.
Good, acanthotic psoriasiform with a regular psoriasis hyperplasia with some involvement of the interface. It's perhaps focally lichenoid. And then what kind of cells are these?
I think they're primarily lymphocytes.
A lot of them are lymphocytes. And then if you kind of look carefully,
There's a plasma cell.
plasma cells.
Yeah.
There's quite a few of them.
Mm-hmm.
Okay.
Uh-oh.
And also notice that these probably are not truly thrombosed blood vessels because you can still see the erythrocytes in there. It's probably just sludged erythrocytes. So this is probably a very erythematous lesion, and the blood was just not percolating through quite as rapidly as it should have been. I don't think this is really a thrombotic vasculopathy, so to speak.
Right. Well, I guess when I think about mixed patterns where there's psoriasiform and lichen, I think that's the most common one for syphilis. So that's what I would think about.
Good. Is that what you thought about before I pointed out all these salient features to you, or did you?
I was definitely thinking lichenoid and psoriasiform, but then when you said the plasma cells, yes.
Yeah, and if you look at low power, again, there's always harp on this, but you can tell these aren't jet black, right? I mean, there's definitely some lightness to them. They're not as dark as we look at, say, a low power biopsy of lupus or something like that, where everything's basically a lymphocyte. You can say, these, I can just tell this doesn't look just perfect for like lichen planus, for example, and it's certainly not psoriasis. And so you might think of like a funny psoriasis drug eruption or something like that. And then you go to higher magnification and you see that the reason those cells don't look jet black is they got a lot of cytoplasm filled with immunoglobulin. So basically, and you can see it's obscuring the dermatological junction here. So this is secondary syphilis, and syphilis can give a lot of different patterns in the skin. I mean, I've seen some that just look, we've talked about, sometimes it looks like pityriasis rosea clinically. I've seen histologically, it can look like pityriasis rosea. I've seen it look like viral exanthem histologically. I've seen it look like vasculitis, like sarcoid. So it can look like a lot of different things. So that's a true statement, is that syphilis can really take on a lot of different histologic pictures. You commonly get parakeratosis because the lesions are often kind of scaly. You can remember you get the little collarettes of epithelium around the lesions on the palms and soles, those ham-colored papules and whatnot. You may get neutrophils in the cornified layer. We don't see a lot of it here. There's maybe a couple, but it's mainly just kind of parakeratosis. Sometimes you can get some diskeratotic keratinocytes with syphilis. I don't really see a lot of that here, but I've seen this simulate also pityriasis lichenoides. And I remember when I was a resident, there was a really good clinician that followed a middle-aged woman who lived in Park Avenue for about a year. He followed her thinking she had pityriasis lichenoides, and finally one of the first-year residents said, "Did you check a VDRL?" And he did, and was positive. And her husband had given it to her, and just nobody thought of a socialite from Midtown Manhattan having syphilis, but she did.
That's wild.
So it's a lesson to just remember. The other thing that the textbooks talk about that I don't recommend spending a lot of energy on is that you get these thick predominant endothelial cells in syphilis. I personally have never used that as a criterion for diagnosis. I don't know that it really is valuable. I mean, maybe that's why these red cells are sludging in here, but I just don't know. Maybe the spirochetes like the vessels too, but most of the time when you do a treponeme pallidum stain, they're located in the epidermis the majority of the time.
So Dr. Cockerell, for hypertrophic hypertrophic lichen planus, you would want to see more. That's the one where you can see EOs, correct?
Sometimes, but that's not a common finding. Mainly in that condition, you see a much denser lichenoid infiltrate with lymphocytes with prominent pseudoepitheliomatous hyperplasia. So you can see a lot of that in hypertrophic LP. Sometimes you can see EOs, but that's not as common. And usually you don't get parakeratosis. It's usually thick hyperkeratosis. If there's any parakeratosis, it's kind of wedge-shaped hypergranulosis, and it's a little bit right above that. But that thing can simulate a cancer. I mean, that's the problem there, is that you get the pseudoepitheliomatous hyperplasia and it gets misdiagnosed as a squamous cell, and then they start doing Mohs on somebody's anterior shin, that sort of thing.
Okay, thanks.
You bet. Okay. I'm going to give this one a go. This one's board 101. So you're going to see on the board examination somewhere, probably about 2 or 3 different places would be my prediction, maybe more.
Yeah, I can take this one. So it looks like, yeah, in the epidermis, we're obviously getting a split. And it looks like it's from, this part just superior to the basal layer.
Yeah. So your pattern then is going to be what?
Thinking of bullous disorders.
Okay. And so when we think about blistering disorders, there's 4 different mechanisms, but 3 primary mechanisms for getting a blister.
Yes, and so you can think of like what you can go down the path of like acantholysis with with or without dyskeratosis. You can think of like with spongiotic dermatitis, and then if it's so if you're thinking of acantholysis, you're thinking of things like Haley or other disorders like that.
Yeah, don't forget also about ballooning degeneration. So those are the 3 major types of intraepidermal vesicular dermatoses, if you will. And then obviously you have subepidermal blistering. So you have intraepidermal, subepidermal, intraepidermal, those 3 mechanisms plus hyperkeratosis, and then of course subepidermal. And then you look at different type of inflammatory cells, whether it's cell poor, if it's cell rich, what type of cell, et cetera. So we got to decide whether this is an intraepidermal, subepidermal blister, and you think it's
It looks intraepidermal to me, I think.
Yeah.
Well, I don't know. Yeah, I think I see the basal layer right there that's still attached.
Careful about that, because there's what's a way that you can be fooled in a subepidermal blister when you see epidermis here like this.
You're saying if you actually see the epidermis there, or if you're like thinking it's inflammatory cells?
Well, let's say that let's just say for the sake of argument that this is actually a subepidermal blistering disorder and not an intraepidermal blistering disorder. What's the explanation if we were to see a field like this, for example? Forget this, because that's the answer, but let's say right here, if we saw something like that, are you going to say, it's obviously intraepidermal blistering disease? It's got, this stuff, and it's got this, and therefore it has to be inside the epidermis that's causing the blister.
I guess I'm not sure with like or where you're getting it for like the reason of why.
Yeah. What's the reason that you might see a subepidermal blister that might look like this right here? It's just kind of an important thing to remember, because I've seen lots of dermatopathologists and residents get tripped up over this over the years.
I guess I'm not sure if it's like, you're catching it in the early stage or something and it just hasn't detached yet. But I'm
actually, it'd be more of a later stage where you get a blister and then it reepithelializes. And then you biopsy it and you see the blister root floating up there. And then you see this reepithelialized epithelium beneath it. And you say, oh, it's got to be an intraepidermal blister. Well, no, actually, we see bullous pemphigoid, EBA, linear IgA, all these kind of things. If you biopsy kind of relatively late, it may actually come in and reepithelialize underneath it, and then you can be fooled. So just remember that's a way that you can be fooled. That's not happening here. You're totally correct. So you're seeing this pattern here, which you said was acantholytic, which it is. And so what's the most likely diagnosis here?
With this acantholysis, I mean, it makes me think of like right here in this thing for Haley. But I think you could also think of like Pemphigus vulgaris, or
I'm glad you said Haley, because if you just saw this field right here, you might say, oh my goodness, it looks like a dilapidated brick wall. That's what you see in Haley. But then you look over here, there's a single cell layer, tombstones and whatnot. And so when you're looking around her, you have to sort of find the area that looks the best. And what do we have here? What's going on in this situation, right in this area?
Well, in this split right here, you see the kind of tombstoning where you see the basal layer at the bottom that's
right
adherent.
And then what do you have here? What do we have this structure right here overlying that?
I mean, it's just the rest of the epidermis there, but there's not like a ton of acantha, like,
Notice
fibers
notice this is a hair follicle. Okay.
there. Oh, okay, gotcha.
And that's really helpful with Pemphigus vulgaris, for example, and superficial pemphigus also, but it tracks down follicles like this. So this is really helpful if you see that. And also notice this part right over here. There's nothing in the top of that follicle. That's totally normal, except maybe the very base of it right here. So you don't have a dilapidated brick wall here. You have normal epithelium, a nice clean split right at the suprabasilar area right here, and then no disc keratosis, nothing. So be careful of trying to find a diagnostic area that can help you. Always look at the roof of the blister. And if it's really pretty thick like this, it means it had to be pretty much a suprabasilar area, because if this were superficial pemphigus, the roof would be about this, up here. It'd be very, very thin. Here we've got most of the epidermis is comprising the roof. You got a few of the acantholytic cells sitting at the bottom, and then you got that tracking down the follicle. And so don't look over here and say, oh God, that looks like a dilapidated, it's got to be Haley, when you've got all these other things here sort of screaming Pemphigus vulgaris at you. So don't let that throw you off on a board examination. Here you've almost got if you just have something like this, you might say it might even be subepidermal, because there's very few cells left over here. So you can see sometimes this isn't so easy for us when we get a biopsy. If we just had something that just showed this, we'd have a hard time calling that Pemphigus vulgaris. I mean, it almost looks like a subepidermal blister. If you had, the other area that you pointed out a minute ago, you might say, oh my gosh, that does look kind of like Haley. We don't really have the roof of the blister. So you can see why sometimes it can be challenging, in the real world, but look for these other features like this and sort of add 2 and 2 together. And yeah, this is going to be Pemphigus vulgaris. So they're going to show you this on the board examination. You'll probably get a histologic picture somewhere. You'll probably get immunofluorescence somewhere. You get a question about, the antigen. You'll get a question about the immunofluorescence pattern. You'll get several questions about Pemphigus. And you'll get questions about some stuff related to Pemphigus. Pemphigus, paraneoplastic Pemphigus. What diseases are associated with. So you're going to get a lot of questions about immunobullous disease. They love it. Now, how would you tell this? Last question, from the Pemphigus vulgaris variant of Grover's disease?
In terms of, I'm not really quite sure in terms of Grover's. I mean, I know that, yeah, I'm actually not sure between the variant of Pemphigus. I guess you'd look for more, again, like of the basal, seeing the tracking of the basal layer, the tombstoming, like in parts of it. Yeah,
well, I'm going to give you the answer. Number one, it's never going to be this diffuse, because it's called focal acantholytic dyskeratosis, right? So it's just be foci. So it's never going to be a biopsy that goes across the entire front like this. You'll just rule it out immediately, no matter what. Number two, and an easy one to remember, is that those conditions, Haley, variant of Grover's, superficial pemphigus variant of Grover's, this variant, never tracks down follicles. So if you see this, like here, Grover's is out. It doesn't go down follicles like that. It's just a little small focal areas within the epidermis. So there are 5 subtypes of maybe 6 subtypes now of Grover's histologically. So if you see a biopsy and the best answer here is Pemphigus, and they're trying to trick you and say Pemphigus vulgaris subtype of Grover's disease, you would never choose that because it goes down the follicle here. So you would know that that's wrong. So now you know.
Gotcha. That's helpful. Thank you.
Okay, you're welcome. Let's take a look at this one here. All right.
I can do this one. It's a punch biopsy.
The bad news about this one is that this is, you only get 1 power.
Oh, okay. It's a punch. It's somewhere with a lot of hair follicles. I mean, probably the scalp.
Good. Good. Is this normal scalp?
I mean, in terms of number of hair follicles, it looks fairly normal to me. Um,
Now, if we biopsied your scalp, would it look like this?
hmm. Oh, yeah. I guess
We hope not.
follicles maybe should
We
be
really hope not. We really-
deeper, you know?
yeah, you would have about 8 to 10 normal, beautiful, luxuriant hair follicles sitting right down here in the subcutaneous fat with nice hair bulbs, and it would look so healthy that, you know, it wouldn't look anything like this. What do you think this person's scalp looked like clinically?
I suspect they're having some problems with hair loss, which is why they got a scalp biopsy.
You would think so. Yes, they've got one follicle in this deep part of the fat. This one's still touching it a little bit. This is a horrible alopecia, unfortunately.
Oh,
There's got alopecia here. Okay, so we know it's an alopecia. But you're right, this is the scalp, and it's not normal scalp. Okay, so you got an alopecia. So what's your approach? Alopecia, very logical. You know, some diseases, they're not so logical, but this one is very logical when you're approaching an alopecia.
right. I think, I mean, is it scarring or non-scarring? Or
Yeah, I
like
think of it as
inflammatory,
as,
non-inflammatory are the
exactly.
sort of main splits that I think about.
Yeah, good. So it's inflammatory, non-inflammatory alopecia. Is it cicatricial or not, or permanent or not? You can ask that and say if it's permanent, is it scarring or non-scarring? You permanent non-scarring alopecia, right? If you're just androgenetic alopecia, for example. And then you ask if it's inflammatory, where's the inflammation located? And then what kind of cells are involved in it? You know, and then you can also ask yourself if there are any other features of it that are kind of helpful. You know, is there, you know, what kind of stage are the follicles in? Is there any, you know, something that looks like they're kind of synchronized or asynchronous? You know, so there's some other variables that you can kind of look at here. So do you think this is going to be a permanent alopecia or a non-permanent alopecia here? Likely.
Um, to me, I didn't think it was a scarring alopecia.
Yeah, it's probably not going to be permanent. I mean, you've still got some residual little follicles here. It looks like these, if they were stimulated properly, could maybe return and grow back, and, you know, things could be good again at some point. And if it's scarring, you always ask yourself, well, where's the scar located? Is it a diffuse scar across the whole thing, like you might see with something like folliculitis decalvans, which is basically just like the Russian army just plowing through, killing everything in its wake? And then you see if it's just targeting the individual follicles, like a sniper shot, especially something like in these areas up here, that's pretty classic for lichen planopilaris or frontal fibrosing alopecia or central centrifugal alopecia, if you see that pattern. So it's not that, and I don't really see any scar here. So I would agree with you. This is probably not going to be permanent and not going to be scarring alopecia.
I mean, I was thinking this was just like androgenetic because it seemed like the hair follicles maybe had like variable diameters and that there was like more prominent like sebaceous glands.
Well, let's look at one other thing too. What stage are these follicles all in here?
Are they all in telogen?
They're actually, this one's kind of almost to telogen. This one's probably heading towards telogen. These are like catagen moving towards telogen. So these follicles have all been hit at the same time. It's almost like a nuclear bomb went off here. And all of these follicles got shifted from anagen into telogen, into catagen, and then they're heading into telogen at the exact same time.
So then like
what disease do you know that does that? There's only one.
Telogen effluvium.
No.
No?
You'd think it would be, but actually telogen effluvium doesn't hit every follicle. It hits maybe, you know, every fifth follicle, every sixth follicle. So when you see somebody with telogen effluvium, they have kind of a, it's not a moth-eaten alopecia, but it's kind of a spotty, they just lose a lot of their hair. They say, oh my God, my hair is falling out. And you look at it, they got, you know, you see the whiteness of their scalp between lots of hairs. If you see this disease, it's all the hairs are gone, or you see little small hairs that look like they're sort of got a funny morphology that are still sort of sticking out because they're being shed, because this kind of goes in a cyclical fashion.
Is it like anagen effluvium, like with chemo?
Yeah, that doesn't really give you quite that same degree either. It's that almost looks a little bit more like telogen effluvium. Interesting enough. Talk about antigen effluvium, because when you biopsy it, you still see a lot of the follicles still in antigen. They just, all the hairs are, the keratinocytes are dead because they get killed by chemo, and it doesn't get killed by the immune response kind of causing the follicles to kind of go into telogen or shifting into telogen. So it looks a little bit different, but histologically, they're just antigen follicles that are dying, and there's not in telogen yet when you biopsy that. But this one, they're all in catagen. This is,
I think that can happen in alopecia areata. It just didn't seem inflammatory enough for me, but maybe I'm not seeing that. Like
that's what I want you to see, is don't always use that criterion for that, because this is one of the conditions, this is the only condition that will give you this massive shift into catagen all at once. So whenever you see this markedly thickened glassy basal membrane surrounding these follicles like this, these follicles have been shifted into catagen, and it can happen without a whole lot of inflammation. So this is the clue to this diagnosis. When everything kind of gets synchronized like this, there's really nothing else that really will do this. And if you maybe biopsied it a little bit earlier, you might see a few more inflammatory cells. So that's why I want to show you this one, because it doesn't show a lot of the little peribulbar inflammation that you classically see with AA. Sometimes you get a relative paucity of inflammation, but everything gets shifted into catagen at the same time. And it's really the only disease that really will do it like this. And you'll see, if they showed you something on the board, they probably would show you something that's got the more classic peribulbar infiltrate and some of that also. But I really want you to remember, this is really, it's just virtually pathognomonic of AA when you see that. This one may have a little bit more inflammation over here possibly, but this is just nothing else does this. So just remember that.
That's very interesting. Thank you.
Yeah. Now, this is another clue. You see trichomalacia a lot of times in patients that have alopecia areata, because they start losing their hair and then they start twisting it and saying, wait, my hair's falling out, and they help it along. And so they commonly get a combination of trichotillomania and alopecia areata. So you see that together so quite a few times, actually. So that's, this isn't just purely trichotillomania. That also doesn't give you this synchronization of the follicles here.
Very interesting. Thank you.
You're welcome. So we got time for one last one. We have 3 minutes. So this is a simple one.
Oh, you can't say that, then I'm not going to get it right. Okay, this is another scalp. The follicles look like they're more in the subcutaneous fat this time, but
yeah, this guy's got plenty of hair.
Yeah, but he has this, what looks like a bunch of more sebaceous glands on his scalp, at least from this power.
Yeah. Anything about these sebaceous glands?
What do you say?
Anything peculiar about the sebaceous glands?
They're quite large.
They are. And notice that some of them don't really seem to be, they're kind of like rogue.
Yeah, they're not opening up to anything.
Yeah, they're kind of sitting there on their own. And here's like about 4 or 5 kind of coming off this funny looking follicle. And what about the overlying architecture of the epidermis here?
Yeah, it's a little acanthotic.
Yeah, and it's kind of, what else
Like,
is it?
It's like what Vandergriff would call sebi to me, but like reticulated almost.
Yeah, and it's also kind of, it's got, imagine if you saw this clinically, it would look kind of papillated or mammillate,
Yeah.
right? It wouldn't be smooth surface. It's above the surface of the epidermis. And then we've got this other interesting little finding over here.
Uh-oh. Well, I think this is nevus sebaceous.
Yeah, good. So
But there's a secondary tumor in there, maybe.
yeah, what do you call this secondary neoplastic process here?
Well, I don't, is that basal? It doesn't look, I don't know. There's clefting around it. It looks like basal cell to me, but
Yeah, but it's not a real classic basal cell, right?
yeah,
In the
it
old
could be
days-
trichoblastoma too.
Yeah, exactly. In the old days, these used to get called basal cell carcinoma associated with nevus sebaceous. They're almost never really basal cells. They're really these little, trichoblastoma-like structures, these basaloid follicular proliferations that are associated with nevus sebaceous. They're not truly basal cells. They really rarely behave like basal cells. Sometimes they may kind of ulcerate and ooze a little bit, but usually this is obviously a pretty young person too. And so you don't really have to take off every single nevus sebaceous that you see in a baby or something like that. Now, so let's say the board gives you this, you get it right pretty fast. What's something they might ask to make it a little bit harder for you?
I don't know, like syndromes or mutations.
Yes, syndromes. So is there a basal cell, a syndrome associated with nevus sebaceous?
Yeah, I think it's called nevus sebaceous syndrome.
Yeah, there is. I think it goes at Schimmelpenning or something.
Yeah, Schimmelpenning syndrome.
And I think they can get like CNS abnormalities and mental retardation, and I think
Ocular abnormalities, I think.
Yeah, make sure you know those syndromes, because if it's obviously a simple diagnosis, they want to make sure that they at least test you somewhat, so you don't leave there feeling like you were cheated. So they're going to ask you something like a second order question possibly about this. I don't think they would ask you, is this really basal cell or not? The answer is no, but they would. You could very well get this on a slide where they might actually show you this and expect you to recognize that this is nevus sebaceous. Okay, that's it. You guys can head off to clinic. And I hope you enjoyed the session, and we'll do this again next